Welcome to this video on allergic fungal sinusitis. Before we begin, consider the following questions. What is AFS? How does AFS present? What are the diagnostic criteria for allergic fungal sinusitis? And how is AFS treated? Allergic fungal sinusitis shares many similarities with chronic rhinosinusitis, and in particular, the type 2 endotype of chronic rhinosinusitis. In this condition, the chronic sinunasal inflammation is driven by an allergic reaction to fungal hyphae. Fungal spores, such as those from Aspergillus or Bipolaris, are ubiquitous in the environment and are regularly inhaled as part of normal breathing. Under typical conditions, these spores are trapped by the nasal mucus and are cleared by the mucociliary system before they have a chance to germinate. However, in some individuals, perhaps due to impaired mucociliary clearance or obstructed drainage pathways, spores may persist within the sinuses, and given the right conditions, they can germinate and develop into hyphae, which are long thread-like fungal structures. The immune system recognizes these hyphae as foreign and antigenic, triggering a Th2 IgE-mediated hypersensitivity reaction. Much like in type 2 chronic rhinosinusitis, the Th2 cells are activated, leading to cytokine release, eosinophilic inflammation, and leukotriene-mediated tissue damage. In addition to the normal consequences of eosinophilic inflammation, allergic fungal sinusitis results in the production of thick, viscous fungal mucin, which is a mixture of fungal elements, typically fragmented hyphae, charcot-laden crystals, which are breakdown materials of eosinophils, necrotic debris consisting of epithelial and inflammatory cell remnants, and high metallic content, including iron and zinc, which fungi require for growth, enzymatic function, and sporulation. It's important to note that allergic fungal sinusitis is a non-invasive condition seen in immunocompetent individuals. The fungal hyphae do not penetrate healthy sinus tissue or blood vessels. This sharply contrasts with invasive fungal sinusitis, a rare but life-threatening emergency seen in immunocompromised patients. Here, the fungus does invade normal healthy sinus tissue and blood vessels, resulting in rapidly progressive tissue necrosis. Allergic fungal sinusitis typically presents similarly to chronic rhinosinusitis, with patients reporting the cardinal symptoms of nasal obstruction and/or discharge lasting more than 12 weeks. However, because it relates to a type 2 endotype, anosmia and nasal polyposis are more commonly seen. A key distinguishing feature of long-standing established allergic fungal rhinosinusitis is bony remodeling due to chronic fungal enzymatic activity. In some cases, this can lead to bone erosion, affecting the orbit resulting in proptosis, the medial canthus resulting in telecanthus, and rarely skull base erosion. Such cases are not seen in chronic rhinosinusitis. On CT scanning, AFS typically presents as sinus opacification affecting multiple sinuses. If a single sinus is affected, such as the maxillary or the sphenoid, this is suggestive of a myocystoma or fungal ball. This is a non-invasive colonization of the sinus, but with minimal immune response or inflammation. The opacified sinuses may contain hyperdense areas due to the high metallic content of the fungal mucin. If an MRI is requested, these same hyperdense areas would appear as hypointense on T2 weighted MRI, helping to distinguish AFS from other sinus pathologies. The Bent and Kuhn criteria are commonly used to diagnose allergic fungal sinusitis, and the patient must meet all 5 of the major criteria. These include a type 1 IgE-mediated hypersensitivity reaction with evidence of allergy, such as a positive skin prick test or high serum IgE, nasal polyposis as a hallmark of fungal sinusitis, characteristic CT findings with sinus opacifications and areas of hyperdensity reflecting the fungal mucin, evidence of eosinophilic fungal mucin, which is thick insipated mucus, and finally positive fungal staining with fungal elements identified on histopathology or culture. Although medical therapy may have a role, allergic fungal sinusitis typically requires surgical intervention. This is because endoscopic sinus surgery is needed to remove the thick, insippated fungal mucin, which is difficult to clear with irrigation alone. As with any endoscopic sinus surgery, wide sinus openings and complete ethmoid exenteration are desirable, but are particularly important with allergic fungal sinusitis to eliminate any potential fungal reservoirs. This is also important to facilitate high-volume irrigation of the sinuses to prevent entrapment and subsequent germination of spores in the future. Wide sinus openings are also important to enable clinical surveillance during subsequent examinations. Finally, postoperative care includes lifelong nasal irrigation and topical steroid therapy to minimize recurrence. I hope you found this video to be useful. I'd be grateful for your feedback in the comment section below, and let us know what you'd like us to cover next.